Welcome to the Pharmacy Leaders Podcast with your host, Tony Guerra. The Pharmacy Leaders Podcast is a member of the Pharmacy Podcast Network, with interviews and advice on building your professional network, brand, and a purposeful second income from students, residents, and innovative professionals.
Hey, welcome to the Pharmacy Leaders Podcast. Tony Guerra. I asked Mike Casehob to come back and talk with us. He had some great tips with Ahmed about becoming an entrepreneur, starting your own business. And I just wanted to ask him some follow-up questions just for maybe some of the people that are graduating residency this year and kind of, or going to go into maybe thinking about a residency next year, and just kind of get his opinion on that point where maybe in your P3 year, you're like, well, what should I be doing? What should I be working towards? So, Mike, welcome to the Pharmacy Leaders Podcast.
Thanks, Tony.
Hey, the first question I wanted to ask you was, so they're talking about how excited they are that they've grown the residencies from 3,000 to 4,500, which is a huge number. That means 5 years ago we had 3,000 residencies, now we have 4,500. But what I guess I'm concerned about is that those residencies don't necessarily teach you how to scale something. They teach you how to work in a job, a clinical job. And I don't know that there's maybe 1,500 extra clinical jobs. I was talking to someone who was going to start working for your company, and rather than do residency, rather than work retail, they're going to go live where they want to and work remotely for you. So tell me a little bit about the advantage of working at Casehob Consulting.
Yeah, so I think, at least now I'm going to have my my skewed view a little bit on this, of course, because it's my company.
This isn't the news. This isn't journalism. We don't have to take both sides. You can just take your side.
I'll be fair and balanced if at all possible.
Why?
That's a big part of our model is, I didn't want to say, hey, I'm going to create this clinical call center and it's going to be in Des Moines, Iowa, and everybody has to live in Des Moines, Iowa, and do this work only here. I believe, there's amazing pharmacists nationwide that can do this kind of work. And so again, as technology improves, we've got that ability to securely work from a remote location. And I think that there's a lot of value to that. So if you want to live in Hawaii and you're surfing most of the day and evenings is when you're going to be doing your work, that's great. And actually internationally, we have some pharmacists that work in other countries. I mean, they're licensed in the U.S., but maybe they spend part of their time in, we've got one person that spends part of their time in Australia. We've got Saudi Arabia, Canada, so you've got those opportunities to really be able to do that. And it allows us to kind of cast our net much farther than just saying, again, we can only hire pharmacists that are within, a 40-mile radius of Des Moines, Iowa. And I love Des Moines. Des Moines is a great place to live, but not everybody wants to live in Des Moines. And so we've got those options of being able to have folks live and work wherever works best for them and their families and where they want to work. And I think that there is a lot of value to that, and at least from my perspective, of course.
You talked a little bit about stability in the beginning of the episode with Ahmed, and I kind of want to talk about that because I almost lost my job, but didn't because the pharmacy tech program ended up getting canceled, and then I ended up switching over to teaching chemistry and pharmacology. But I feel like while we used to have stability in that kind of retail job, okay, well, I'm going to work, the 40 hours. We just hear, I think, out of Ohio, there's a company that just said something to the effect like, okay, well, managers will have stable positions. We're not sure how many hours the rest are going to get, and you might all have to take a 20% pay cut. So I'm not sure about the details or the truth in that, but I am sure about the truth that things are changing. How does the job that you have or the jobs that you're providing maybe provide stability in a different way in a new economy?
Yeah, I think that's a great question, and I definitely feel like there has been a shift, even in the last maybe 5 years, 5 to 10 years. I mean, when I graduated from pharmacy school, probably the same time around you did, Tony, as well, too, is you could kind of write your own check. You could kind of say, hey, I'm going to kind of go wherever I want to. And those were the good old days when there were people offering BMWs, $20,000, $30,000, $50,000 sign-on bonuses, that kind of stuff. Well, those days I never got my BMW. I guess
I didn't either.
I could have, I guess, if I wanted to go certain places. But the landscape has changed so much since then too. And I think there's so many people that graduate and they can't find a job, or they can only get part-time, or they can only float. And so I'm not saying we're capitalizing on that, but I think that's also a little part of what we're trying to look at is, what does this look like in 5 or 10 years? Are we going to have this huge surplus of pharmacists that can't find a traditional job, or they can't find full-time work, or whatever they're looking for? They have to, move to some place that they don't really want to live, but they have to do it because, they owe, $200,000 in student loans, and, they can't make much money working at McDonald's, that kind of stuff then too is the reality where a lot of people are at. So I'm not saying we're focused so much on that, but I think that there can be a component to that where there is likely going to be this surplus of pharmacists that want to be clinical. And that's the other thing, is that we've got pharmacists that want to be in a clinical position, and that's purely what we do. I mean, we're spending our whole day working with patients and identifying drug therapy problems and resolving those drug therapy problems. And I think that there is a pretty interesting model there that we're keep expanding on. But back to your question about stability, I have people reach out constantly about, hey, I've just lost my job, or they just cut back our hours, and now, I'm not making nearly what I was before. And I think that's really the reality. And there's, a lot of different reasons why that's happening. A huge part of that is reimbursement. Pharmacy just isn't as profitable as it used to be. And, most pharmacies can't afford to have 4 pharmacists on staff, or whatever. They can hardly maybe afford having 1 pharmacist on staff then as well too. So I think there's a lot of different reasons why that's happening, and I think that we can fit nicely into that, where we can either supplement that for some people. So we've got a lot of folks that might work part-time somewhere, or maybe even full-time somewhere, and then they work for us on the side part-time. But we also have a lot of folks that work for us full-time as well too. So it's definitely changing. And I think that, as more pharmacy schools are opening, it seems like everywhere there's more and more students that are applying. And there's this bubble, and this bubble is going to be bursting, I think, in the very near future. And, I'm concerned about what that does to our profession. And, I love this profession. I love what we do. I love what pharmacists do and what we represent. But I am a little concerned about what this looks like long-term and even short-term. And I think that that's where we have focused on shifting away from what does a traditional pharmacist do to saying, what can pharmacists do? What are some other things that pharmacists can do that don't require you to go work retail, or go work in a hospital, or go do, this or that. And I think there is something there. And I think what we really need to do is just keep scratching away at that surface and show physicians and other healthcare professionals and payers what pharmacists can do, and really focus on that. And again, have it in a scalable model. We can really help move the needle. And that's something I've always tried to focus on is, again, I don't want to just have, 2 pharmacists that kind of help do some things. I want to have hundreds or thousands of pharmacists that can really say, look what we can do, and look what we've really done to impact healthcare in the U.S. Because we all know it's broken. We all know the healthcare in the U.S. is really, really, it's a cluster. It's a really big mess right now. And I think pharmacists are really underutilized. And I think that there's a huge place where we can play. But we also have to make sure financially and the economics all make sense with it too. So that's something that I'm always constantly stressing, is how can we make sure that financially this is viable and it's a model that we want to do. And I'd love to do all this for free, but it's really hard to recruit pharmacists that would be willing to do all this for free too.
Well, let's talk about that, because I think that's one of the biggest barriers to being an entrepreneur or being on your own. I was a real estate agent for Gosh, 7 years. And the big change for me was going from, working at the pharmacy and then doing the real estate thing and having variable income. So I made the switch in February, which is probably the worst time to do it because there's no income coming in. People buy and sell houses in April. So like you, I went in, I dove in the pool and I was like, it's awfully shallow. Where's the water? What happened? But I didn't have wife and kids at the time. So I guess my first question is, you went into a variable income job, but you were always working these other jobs, getting other skills at the same time. So that whole, 10% of businesses are going to succeed after a year. And then of those 10% will still be there in 5 years. Doesn't really apply as much when you've been really working this job at the same time as you've been working traditional jobs. Can you talk a little bit about what it is to have variable income and how to kind of set up the nest egg? I'm absolutely petrified of it. So I keep 2 years worth of salary in the bank. And my wife's like, you got to invest that. And I was like, I am, in my peace of mind.
Yeah,
But tell me about variable income, because I think that's the big thing. It's like, oh, no, it's too risky to leave my position when, a week later their position's gone. And they're like, all right, well, maybe that wasn't risky.
Right. And I think, yes, it is very risky, of course, but I'm captain of my own ship as well too. And that doesn't mean that tomorrow, something could happen and we could go completely belly up. But that's the reality of any job that you have. And I think that's a veil that I think we need to kind of remove from people's eyes a little bit of, oh, well, I've got a stable job and I work at fill in the blank, and oh yeah, they're not going to have any cutbacks. And then the next week, you're not the one making that decision. You're really at the whim of those folks that are above you and those, those stockholders or whatever that looks like then too. So, variable income can be very, very challenging. And as I kind of mentioned on the first podcast we had done, is that you just have to be okay with that. You just have to have a comfort level of knowing that this could all go away tomorrow. And that's really not unique in business at all. I mean, any company could really go belly up. You as an employee may not really know that until, the memo comes out, or, you get the phone call that tomorrow we're shutting the doors or whatever then too. So it is a different type of risk, but for me, it is risk that at least I have some control over a little bit, at least, or I'm able to pivot and say, oh, that didn't work. We're going to pivot. We're going to try some other things in too. And for me, I've got insight into that. Of course, I know kind of how things are going, and I know what's in our sales pipeline, and I know what discussions we've had. And so I have some comfort level with that because I know and I have insight into that. And that's something we try to be really transparent with everybody that we work with then as well too. So all of our pharmacists and stuff, we try to give them ideas of, hey, this is what's coming down the line, or hey, this is what's happening, because I don't feel like it's fair to keep that kind of information from them because they have to make those kind of decisions as well too. And so I wish I had 2 years of income in my savings. However you did that, that's great. I mean, I'm not quite there yet, but it is a struggle, I would say, to really try to figure that out, like really try to stabilize what that income looks like. And I feel like at this point we're fairly stable. I mean, we know what's coming down the road and what deliverables and what invoices we have coming in and that kind of stuff. And so we're pretty comfortable with where we're sitting at. But we're constantly looking to bring on new business and what that looks like then as well too, and having different partnerships as well then. So, again, I think when you get to the point of just saying, I'm okay if tomorrow everything just went away, you just have to be okay with that. And you just have to you could get hit by a bus tomorrow and, then you're not going to that sounds, again, back to cliches. But it does, you can't just live your life constantly in fear of what's going to happen tomorrow or next month or next year. And that doesn't mean you don't think about those things or you don't try to, plan and be prepared for those things. But having those conversations in your head constantly is counterproductive. And from my perspective, and that I try to really focus on what's going on right this second and to really try to be in the moment, try to be mindful of that. And I think that's for me just a philosophical belief that I've got, is that I can't change what happened in the past. I really can't change what's going to happen in the future. All I can do is just kind of focus on what's going on right now. And that can be, it might be cheesy, but that can be really freeing as well too, because I don't have any control over that. And all I can do is just focus on what I'm doing right now then too. But again, back to, you just have to be comfortable with that kind of risk. And if you're not, you're kind of, you're maybe a little deer in the headlights that again, tomorrow you could lose your job, and there's really no such thing as stability.
Yeah. Okay. Well, I'm going to be hosting a Careo chat here in an hour and 10 minutes. And I guess, the visual that I have of somebody going in, the chat is about, what it is to be a pharmacist in a physician's office. How does that work and all of that? And I guess I feel like the way that many students look at it is, so let's say they go into the physician's office, the receptionist comes up and says, "Oh, hi, are you a drug rep?" Nope, I'm a pharmacist. Yeah, but so you're here as a drug rep? No, I'm here to work with the physician. So I get it. You're going to help us learn about medicines, but no, I'm here to work in the physician's office. So I guess there's really misconceptions about what it is to be a pharmacist in a physician's office as part of the chronic health team, and then also talking kind of about population health. What would you talk about in that talk? And you're welcome to come on the Twitter chat. Hopefully you'll be able to make it. But yeah, what would you kind of say in terms of, first of all, how does the pharmacist work within the office? And then how does working within the office impact population health in general?
Yeah, I think it's really hard to paint a broad stroke and just say every physician needs this, and this. I mean, I think if you talk in generalized terms, most physician offices they're very busy. I mean, these docs, they have to see so many patients per hour. I mean, you talk about, we have to fill so many prescriptions per hour. Well, physicians are getting to that point where they have to see so many patients per hour then too. So whatever you can do to help decrease that time without impacting quality, or actually improving quality if at all possible. And if you think about that patient that walks in the door that, oh my gosh, they're on 30 meds and they've got, 17 different disease states and all of this kind of stuff. And so if you can really help that physician by taking some of that load off of their shoulders. And, something we struggle with is, how do you get reimbursed for that kind of service? So what we focus on is chronic care management, also complex chronic care management, and because those are billable services. Also, some other things that we focus on is transitions of care, because if you can help ensure that that patient's been discharged from the hospital and you've done follow-up within 48 hours with that patient, and you've done the medication reconciliations and that type of stuff, then when that patient comes in, within 7 to 14 days, that's an additional service, or that's an additional billable service that the physician can bill for now, because this is really a transition of care versus a traditional E&M CPT code that they would use. So there is, understanding the economics involved in that, because physicians they're business people as well too. And, to go to an office and say, hey, I'd like you to pay me $100,000 a year to be your pharmacist, they're going to say, okay, well, that's great, but how do we afford that? Like, how, what can you bill for, and that kind of stuff then too. And really thinking through that, I think, is really important. But over and beyond just what can you bill for, it's also focusing on what are physicians being held accountable for. What types of metrics are they being graded on now, which is impacting their reimbursement, just the same way that pharmacies and hospitals and health systems, and they're being held accountable as well too. And their reimbursement is moving away from a fee for service and more, for other types of, value-based, reimbursement and that type of stuff then as well too. So I think being able to talk to a physician or an office manager regarding what kind of revenue can you bring into the clinic, but also being able to talk about how much additional savings you can help that physician, not getting dinged, not getting bad report cards, and being able to stay in network and get a higher reimbursement than what their colleagues would. I think that's really important. I think that's a huge part of what pharmacists can be doing, but also easing the work burden from their staff as well too. Taking time or allowing more time for the physician, allowing more time for the nurse, and the pharmacist being really a big part of that care team. I think the other challenge is that traditionally those positions have been maybe filled by academic, pharmacists that work in, pharmacies of school, or their students and that kind of stuff then as well too. And I think that's a great place to start, but it's not, back to scalability, it's not scalable. And we need to be able to almost move away from that model of saying, hey, here are these free pharmacists or free pharmacy students that can do this work. We need to figure out how do we convert that over and say, well, there's value to this, and it's not just a free service we're going to offer. Pharmacy, we're really good about giving away stuff for free because we've done it forever.
Stop it. Just stop it.
Giving away stuff for free. And again, I'm not pointing fingers at anybody.
Yeah, I know.
As a business person, I can't do this for free. I can't just go to a clinic and say, yeah, this is great. Look what all we can do. And we'll just do it for free because it's the right thing to do. Because, I don't know. It's
I get where you're going.
We definitely focus on or struggle with sometimes.
Well, let's talk about, I was at Drake next to you, literally. Your table was there. You were talking to students that are going to be doing APPEs with you. Can you tell me a little bit about what an APPE experience would be like with KSOP Consulting?
Yeah, that's great. So our students will get to experience a lot of different opportunities. So, a huge part in our bread and butter has really been around MTM or medication therapy management. So the students will be spending a lot of time doing that and focused on, case management that kind of goes along with that and presenting those patients and focusing on what does MTM look like in kind of a traditional model, but we're also trying to look at it from a virtualized network and how does that all work then too. So that's a big part of what we do. The students will also be really involved in chronic care management. So we've got clients that, our physician offices where we are doing the chronic care management with those patients and working directly with the physicians and creating care plans and uploading that information to the electronic medical records. And that's another huge component is trying to navigate those waters with interoperability and getting access to EMRs and some of that kind of stuff then as well. Also, another big part of what they would be spending time doing is we do medication synchronization as well, too. So we have clients where we are working on behalf of the clients or their pharmacies where we are helping adherence rates by doing centralized medication synchronization. So we're reaching out to patients on behalf of their pharmacy. We're syncing up those patients, kind of getting those pharmacies prepped and ready for them to start taking over the appointment-based model as well, too. So we think that's pretty interesting as well. And as we keep growing and bringing on new business, we just keep expanding. And I think understanding or realizing there's a whole myriad of additional types of things that pharmacists can be doing. And we've got that ability to try out those different models and see what kind of works. So, but really the students will be focused a lot on that. Also be doing like drug information. So, with all of our pharmacists there's oftentimes a question that comes up and says, oh, hey, I've got this patient that's on, 2 calcium channel blockers and we can't really figure out why. Is there any like studies out there? So the students will be helping grab some of that information or doing some research and, they'll be doing article, case reviews and article reviews and that kind of stuff then as well too. But we think it's gonna be fun. We are hoping the students are really gonna enjoy it and hopefully open their eyes to some additional opportunities that might be out there that they hadn't really thought of before.
Okay, well, as a final question, right now I don't believe you have a residency. Right now your residency is, well, I can't hire you as a resident, but I can give you full-time pay or double residency pay, and then you can learn a lot of stuff that maybe you would have learned in a residency. But let's just imagine that you had a residency or you created one. What would be a perfect residency for you? Or maybe what would be a good experience that someone's had in a residency that would prepare them to work with you?
Yeah, I think, and I've got some experience with residencies. When I worked at Hy-Vee, I helped set up a residency with the University of Iowa and Hy-Vee. That's been a number of years ago, but I think residency is really important for for certain folks. I mean, for some people, I ended up not doing a residency. I just decided for me that wasn't the best.
Why do we feel so bad about that? You have to apologize.
Yeah, I decided I didn't want to do.
I'm sorry, I'm hiring 300 pharmacists, but I didn't do a residency, and it's like a black mark on the record.
I don't know what I'm doing, but again, I'm not knocking residencies, because again, for some people it's great.
Sure.
And honestly, I felt a lot of guilt because I was getting a lot of pressure from my faculty that, hey, you really need to do residency. And again, that's fine, but I just decided that wasn't for me. But I feel like for us, kind of a perfect residency, or what we would really want to get out of with a residency, is really focused on not so much the clinical. I mean, clinical is important, but it's more the business side. Like, how do you have a sales call? What types of programs can we offer? Understanding, what does this look like? How do you build a business, and how do you maintain that business from an operations standpoint? What reporting are you looking at? And some of those types of things then too. So I would see it as almost more like a managed care type of residency. Mm-hmm. Versus, it wouldn't be like a traditional PGY1 or PGY2 or anything like that, but it's more focused on business with clinical involved as well too, but really focused more on the business aspects of it.
Okay. Well, with the managed care, half of them aren't accredited, so you don't have to deal with that. So that's kind of nice. So that's
there
good.
You go.
Okay. Well, you've been really generous with your time. Thanks so much for being on the Pharmacy Leaders Podcast.
Thanks, Tony. Appreciate it.
Support for this episode comes from the audiobook Memorizing Pharmacology, a relaxed approach. With over 9,000 sales in the United States, United Kingdom, and Australia, it's the go-to resource to ease the pharmacology challenge. Available on Audible, iTunes, and Amazon.com, in print, ebook, and audiobook. Thank you for listening to the Pharmacy Leaders Podcast with your host, Tony Guerra. Be sure to share the show with the hashtag #PharmacyLeaders.